Good morning, good afternoon, and welcome to MS Connect 2021. My name is Gabrielle Vito, and I'm a longtime volunteer with the MS Society. I'm coming to you today from Parksville, BC, on beautiful Vancouver Island. I'm so glad you're here. To kick us off, I'd like to share a little bit about my story. I was diagnosed with MS back in 1996. I was just 27 years old. I knew nothing about the disease and was a newlywed. It significantly changed my life and career plans, as I'm sure many of you can relate to. I might not be able to travel or work as I planned to, but nowadays, everyone knows what that feels like. Being able to give back is important to me, and volunteering has definitely helped me find a new normal at every stage of my MS journey. I've volunteered in various capacities for the Society over the years, most recently with the MS Ambassador Program. And my friends and family join me every year in raising money and awareness for the MS Walk, which of course is happening next month. I'm so pleased that so many of you are joining us from coast to coast to coast, no matter how you're joining us on your smartphone, your tablet, your computer, or over the phone. This special 2-day spring edition of MS Connect provides us all with a chance to learn and engage, no matter where you or a loved one is on their MS journey. At a time when being connected is so important, we're grateful to be able to provide this opportunity for the MS community to come together in a safe and meaningful way. As we kick off MS Awareness Month on May 1st, we all know that research is the key to preventing and stopping MS. Now more than ever, we need to ensure that this momentum continues. That's why I'm so grateful to hear the latest updates directly from MS researchers who are making discoveries that can have an effect for all of us. Now, before we begin today's presentation, please allow me to share a few housekeeping details. First issue questions. They can be typed into the question box at any time throughout today's session. Join the online conversation and share any favorite moments you have from today's session by posting on Twitter. Please use the hashtag MSConnect. Make your voice heard and respond to our daily poll. That'll be on the Twitter page. That's at MS Society Canada. And this session is being recorded and will be shared at a later date on msconnect.ca. Now, I'm honored to have the opportunity to introduce Dr. Ruth Ann Marrie, who will be discussing her recent study about living with MS while dealing with co-morbidities. Those include cancer, depression, or anxiety disorders. It's so important to talk about the impact of other diseases on MS, especially when it comes to mental health, and what all of this means alongside COVID-19 in today's world. Dr. Marrie is a professor of medicine and community health sciences at the University of Manitoba. She currently holds the Waugh Family Chair in Multiple Sclerosis. She serves as the chair of the MS Society's Medical Advisory Committee, and she was the 2019 honoree at our Women Against MS Gala Luncheon in Winnipeg. So please join me in giving a warm virtual welcome to Dr. Ruth Ann Marrie.
Good afternoon, everyone. I'm really happy to be able to talk to you today about the topics of cancer, depression, and anxiety disorders and multiple sclerosis. This has been some ongoing work that we've been doing for the last few years. These are my disclosures. So the cancer, anxiety, and depression are examples of coexisting or comorbid conditions. So comorbidity refers to the total burden of illness other than the condition you're interested in. Another example would be diabetes in someone with multiple sclerosis. This is common in the general population and worsens with age. And we know that having comorbid conditions can be associated with worse physical function, decreased quality of life, decreased mortality. And so this is part of where my interest in this area comes from. So for today, I'm going to focus on more narrowly a couple specific comorbid conditions. So one, cancer, in particular the risk of cancer in people with multiple sclerosis, as well as depression and anxiety disorders in people with MS. So cancer is a group of diseases. Cancer cells grow and divide without stopping and spread into nearby tissues. And just 4 cancers account for half of all cancer deaths in Canada. In particular, 2 of these are breast and colorectal cancers. So I became interested in this question in large part because of questions that I commonly received when I talk about other comorbid conditions in people with MS, and because this question comes up more and more often when we're using some of the stronger disease-modifying therapies. So a question I'm often asked really is, how often do people with MS get diagnosed with cancer, and is it different than in people without MS? And the answer is we don't know that much before we did some of our studies about how often people with MS develop cancer. There have been a number of studies around the world, but they often included different cancers over different periods of time, often had very small numbers of people with MS included as well, which made it hard to be certain about things, and sometimes they got different answers. So you might ask, what factors might increase the risk of cancer in someone with MS? Well, we know prior to MS diagnosis, at least, people with MS are more likely to smoke. We know after diagnosis, people with MS are less physically active, more likely to be obese, and these are all factors that can influence cancer risk. And we know that some chronic immune suppressing therapies can also increase cancer risk. On the other hand, there are some factors that might be protective. So our immune system plays an important role in ferreting out abnormal cells and deleting them before they can develop into cancers. And so the immune changes in multiple sclerosis actually might, in this situation, work to advantage by improving that immune surveillance. So we aim to try and investigate this question. So we use data sources that are referred to as administrative or health claims data. So every time you see a doctor or get hospitalized, as part of the reimbursement for those services, essentially a claim or a bill is sent into the government that includes information about the diagnosis and the service delivered. And researchers can get access to those data sources, databases, after they've been anonymized so that you can't identify who the individuals are. So in this particular study, which was supported by the MS Society, we obtained access to information about hospitalizations, about services received from physicians or nurse practitioners, about cancer. So we used cancer registries, which capture all cancer cases in the provinces in which we did our study, including the date of diagnosis and type of cancer. And we used population registries and vital statistics, which give us information about dates of birth and death and healthcare coverage, as well as cause of death. So we obtained access to those types of data sources in 2 Canadian provinces, so we could establish that our findings could be replicated and were generalizable. So we did this in Manitoba and Ontario, and using some tools that we developed in previous work, we identified individuals in those provinces over the age of 18 years who had multiple sclerosis. You'll notice here, I've indicated the time period for the studies. These are slightly different in the 2 provinces based on the availability of the data, but you'll also notice that the minimum amount of data we had available in each province was over 20 years. So that gives us a fairly large set of numbers and a lengthy time period to evaluate this question. So when we combine the numbers from the 2 provinces, you can see that we identified nearly 54,000 individuals with MS. Once we identified the individuals with MS, we sought to identify other individuals who did not have MS, but were of the same sex, born the same year, and living in the same part of the province. And we identified 5 such individuals for each person with MS. And so that gave us a comparison or control group of nearly 267,000 individuals. So this was a very large study, and I believe the largest of its kind to date. So then we looked back from the point at which people with MS had been diagnosed, and the people in their matched group were given the effective date of diagnosis as their MS case. We followed them forward in time through linkage to the cancer registry to see if they developed cancer. So I'm going to have you concentrate on the top slide here. So these are our results about breast cancer. So on the y-axis here, this is the number of newly diagnosed breast cancer cases in every person year. So person year indicates, if it's one, that one person was followed for a full year, or it could indicate that two people were followed for half a year. And so those 2.5 years would add up to 1 year. So in that time, this is essentially the risk of breast cancer, and you see 4 lines here. So the first one in sort of a salmon orange is individuals with MS in Manitoba, as compared to the control group in Manitoba. Similarly, we have the Ontarians with MS and the comparison group. And you can see that in both provinces, across all ages, we saw a similar risk of breast cancer in people with and without MS. You do notice some differences in the breast cancer risk in Ontario and Manitoba, which wasn't the focus of our study, but is an already reported difference. So we then did some additional analyses in which we accounted not just for age, but also for region of residence in the province, socioeconomic status, age at MS diagnosis, whether or not the individuals had any other coexisting health conditions and healthcare system use. And even with accounting for all of those other factors, we continued to find no difference in the risk of breast cancer. So if I now direct you down here, we're now looking at colorectal cancer, and you see a similarly structured graph. Again, the sort of orange and salmon pink colors refer to the Manitoba numbers, and the green ones to the Ontario numbers. So in Ontario, you see that there appears to be very little difference in terms of the risk of colorectal cancer between people with and without MS across all ages. There might look to the eye like there's a little bit of a difference there with a lower risk of colorectal cancer in the Manitoba population, but the numbers were much smaller, so the margin of error was greater. And when we combined the numbers across the 2 provinces, there was no difference. And when we went through, again, those additional steps of accounting for other factors, like where people lived, their socioeconomic status, and other health conditions, there was no overall difference in the risk of colorectal cancer between people with and without MS. So I told you, in addition to cancer risk, I was going to talk about depression and anxiety disorders, and you might ask how I chose to focus on those in particular. And this figure really illustrates why. So in a previous study, we identified individuals with newly diagnosed MS in 4 Canadian provinces, this time British Columbia, Manitoba, Quebec, and Nova Scotia, so that we got a spectrum of provinces across the country. And we looked in particular at the percentage of individuals, as illustrated on the y-axis here, who had a coexisting or comorbid condition at the time of their MS diagnosis. The most common diagnosis here was depression, followed closely by high blood pressure, and then we see that chronic lung disease and anxiety disorders are pretty much tied. So given their high frequency, even at the time of diagnosis, this is what I'm going to focus on for the rest of this presentation. So before we move forward, I think it's important that we just review for a moment what depression and anxiety disorders are. So depression refers to feelings of sadness, loss of interest in activities, and this can reduce your ability to function at work and home and other roles. Anxiety is a normal reaction to stress, but anxiety disorders refer to excessive anxiety or fear that impairs the ability to function. So in this particular graphic, we again used health claims data, this time in the province of Manitoba, and we looked at how often people with MS were newly diagnosed with a psychiatric disorder. And so we're looking at this on an annual basis, and you can see for every 1,000 person years, so 1,000 people followed for 1 year, for example, we would see that 30 individuals would be newly diagnosed with depression if they had MS. And this is almost 2.5 times how often you would be diagnosed with depression if you didn't have MS. Similarly, anxiety disorders occurred a bit less often than depression, so the risk is slightly lower, but still 1.5-fold times more risk than in somebody without MS. You may be less familiar with bipolar disorder, but this condition also occurs more often in people with MS than without MS, and we found about a 2-fold difference in risk there. And we found a slightly increased, but not statistically significantly increased risk of schizophrenia in people with MS. So the increased risk is not just confined to depression and anxiety disorders, but more generally across all of the psychiatric disorders that we looked at. Even more interesting, if we look at this graphic here, is that depression affects people with MS even before they're diagnosed with MS. And this can be more common. So in this particular figure, if we look here on the x-axis, this 0 is a marker for the year the individual was diagnosed based on those health claims data. The yellow here are people with MS, and the blue are people without MS, again, matched on their year of birth and their sex and where they lived in the province. And so what you notice here is that, as we talked about before, the percentage of people with MS who have depression is higher than in people without MS. But this is also true even when we go back 1 year, 3 years, and as far out as 5 years. And actually, I haven't shown it here, but even if we go out 10 years, there's still a difference in terms of how often people with MS are affected with depression. And this is, although I'm showing you a depression graph here, this is also something that we see with anxiety disorders and to a lesser extent with bipolar disorder. So, of course, the key question is really not just how often these conditions occur, but what's their impact? So we can think about, and I tend to think about, how comorbid conditions affect people with MS throughout the entire trajectory of their disease. So we can begin at the time when symptoms first begin, and then look at what the status is of people at the time they're diagnosed. We can then move on and look at how it might influence relapse activity and disability progression, how it may influence the choice or effectiveness of treatment, and how it may affect long-term outcomes such as quality of life. So although I'm not going to go over all of these in detail with you today, what I can tell you is that where we've looked at it broadly, having other health conditions at the time your symptoms first begin with MS will delay diagnosis, can be associated with greater disability at diagnosis, that some comorbid conditions will increase the risk of relapses, can accelerate the rate at which disability occurs, can influence the choice of treatments and potentially respond to treatment, and reduce quality of life. So let's talk about things in a slightly more focused way for a moment. So this is a study that I was involved in that was led by Dr. Amber Salter using data from the CombiRx trial. So this was a clinical trial which compared the use of interferon beta-1a, so Aminex, glatiramer acetate, Copaxone, to the use of both medications at the same time. So we were able to get access to those data, again anonymized, and we were able to identify the presence of several specific comorbid conditions, and in particular here we're focusing on anxiety and depression. And so we looked at what the influence was on relapses. So if you look at this particular figure, so anything falling on this side of the line indicates an increased risk, and anything falling on the other side of the line indicates a decreased risk. So if you look at anxiety disorders right here, you can see that there's about a 30% increased risk of relapse in an individual with an anxiety disorder. This is pretty similar to the increased risk associated with high cholesterol, but unexpectedly for me, depression was not associated with an increased risk of relapse in this particular study. So relapses are one aspect of MS, but there are many other important ways that we could imagine depression and anxiety disorders might affect an individual with MS. So most of the rest of what I'm going to show you is based on a cohort study that we conducted and are still conducting for several years with support from the Canadian Institutes of Health Research and the MS Society of Canada and Crohn's and Colitis Canada. So in this particular study, we enrolled 255 people with MS, and we were interested in how depression and anxiety disorders affected people with MS and whether this was the same or different as people who had other immune-mediated inflammatory diseases, such inflammatory bowel disease, which affects the gut, or rheumatoid arthritis, which affects the joints, and whether this differed from the experience of people with depression and anxiety disorders who didn't have any of those kind of immune conditions. So you can see the number of individuals that we enrolled at the top. We asked people to come back for after their first visit for 3 subsequent visits. We did end up with fewer people over time for a combination of reasons, including people moving away, getting lost, or indicating they no longer wanted to participate. So what did we ask people to do? Well, we asked people to come in for standardized assessments at each visit. These included at the first visit a structured psychiatric interview, completing multiple questionnaires about symptoms of depression and anxiety, measures of disease activity. So in MS, we focused on relapse rates, measures of physical function like the timed 25-foot walk and the 9-hole peg test, which measures upper limb function, which some of you may do during routine clinic visits. Measures of cognitive function, which we'll talk more about in a moment. And we also asked people to fill out questionnaires about their quality of life and ability to work. The latter we'll talk more about in a few minutes as well. So let's talk a little bit more about cognitive function or cognition. So what is that? It's how we think. How well do we learn? How do we remember new information? How efficient are we at perceiving the world around us and then acting on that information? How well do we multitask? So we asked the question as to whether comorbid symptoms of depression and anxiety affected cognitive function. So I was interested in whether this affected people with MS and whether it was any different than people with inflammatory bowel disease and rheumatoid arthritis, because MS affects the brain, which is an important source of mood symptoms, but also where our cognitive function resides, and the other conditions were not. So I thought that the impact might be worse in people with MS than in the other conditions. But overall, our hypothesis or theory was that if your symptoms of depression and anxiety were worse, then you would have more cognitive impairment. So this summarizes what we found. So I told you our question was really, did anxiety and depression affect the cognitive function of people with MS, and how did it compare to the other groups in our study? So what we found was that if you had worse depression symptoms, as illustrated over here, you were slower in terms of your ability to perceive the world around you, to sort of handle or process new information. If you had higher symptoms of anxiety, not only did you have slower processing speed, you also had more difficulty with memory and the ability to learn. The surprise for me was that the effects here were the same in all of our groups. They actually were no worse in people with MS than anybody else. Everybody had similar kinds of impacts. But the important finding from that is that given the negative impacts, it may imply that effectively treating depression and anxiety could actually help benefit cognition in people with MS and the other groups that we studied. So that's looking at the effects at a single snapshot in time, but symptoms of depression and anxiety may persist over time or they may fluctuate. So one of the questions is do the effects on cognition also change when symptoms of depression and anxiety change? Given what I told you about wondering about whether we could mitigate things if the symptoms improved. So in this particular graphic, if we start on the first panel, which is anxiety here, we see for each of the groups the percentage of people who had elevated symptoms of anxiety at each of our 4 study visits. You can see it was highest in the group who were enrolled because they had a depression or anxiety disorder. But you can see in the 3 immune disease groups, and MS is the blue group here, that there was over 10% of individuals who had elevated symptoms of anxiety at each study visit. This fluctuated a bit between groups and individuals from one visit to another. We similarly saw persistent symptoms and fluctuations from one visit to another for depression as well. Here you see more variation from visit to visit and between groups than you did with anxiety. So for this, we focused on processing speed, right? So that's how quickly we perceive the information around us and are able to use that information. So again, in this picture, the yellow columns are people with MS. The orange are people with inflammatory bowel disease, the yellow with rheumatoid arthritis, and the green are individuals with depression and anxiety disorders who don't have any of those immune conditions. So the first thing you notice at the first visit here is that people with MS are more likely to be impaired with respect to their processing speed than people in any other group, and this holds true across all the study visits. You also notice that there's some fluctuation in the percentage of people who meet our definition for impairment across study visits. The second question, once we've observed that, is what are the effects of depression and anxiety if we look not just at a single visit, but at all 4 visits? Well, similar to what we found when we looked at our snapshot, is people in any group who had elevated symptoms of anxiety had lower processing speed and more difficulty with learning and more difficulty with working memory than people who didn't have elevated symptoms of anxiety. So it was consistent across all the visits. The question that we were really interested in, though, is what happens if I didn't have any elevated symptoms of depression or anxiety at one visit, and then I acquired elevated symptoms? What happens to my cognitive function? What we found is if you newly acquired symptoms of depression, then that individual would have a corresponding decline in their processing speed at that visit. We could also say it in reverse. The individuals who had improvements in their symptoms of depression had improvements in their processing speed. So this was true in each group. We did not find that changes in the symptom of anxiety were associated with changes over time. So what's the bottom line? In general, having elevated symptoms of anxiety or depression are associated with worse cognitive performance. Those are tests that we're doing paper and pencil or computer to assess function. People are often really more interested in what it means in terms of their day-to-day ability to function. And one of the very important roles that people often have is working. So how do depression and anxiety affect the ability to work? So this is another question that I mentioned that we looked at. So we're again interested in particular how these 2 symptoms affected the ability to work. We also recognize that fatigue and pain are very common symptoms in people with MS and are often closely related to symptoms of depression and anxiety, such that we found it difficult for this question to completely pull them apart. So we looked at the ability to work, and in particular, we looked at it in 3 different ways. So one was general impairment when you're at work, what we called presenteeism. So you're at work, but you're actually really not functioning very well in doing your job. Absenteeism, where you are missing time from work. And the third, where you just have general impairment in your overall ability to function, not just including work life, but home life as well. And we found that this combination of symptoms, anxiety, depression, pain, and fatigue, collectively interfered with all of those domains. So given the frequency that I've told you about of depression and anxiety disorders in people with MS and their impacts, an important question is, do people with MS perceive a need to do something about that? So we specifically asked the question as to whether or not people felt they needed mental health care. And within our study group, 1 in 3 people reported a need for mental health care. This was more likely if you had existing anxiety symptoms, so you were 2 times more likely to say you needed mental health care. And if you had elevated symptoms of depression, you were 6 times more likely to indicate you needed mental health care. And this was based on symptoms, and this was a bigger driver than whether or not you actually met all the formal tick boxes for a formal diagnosis. So just having worse symptoms, even if you didn't have all the parts that were required to make a diagnosis, was enough for people to feel they needed support. Which then gets us to the question of, if somebody feels they have a need for mental health care, what information do we need to share to help someone with MS make a decision about what kind of treatment or intervention might be helpful for them? So we asked the participants in our study when we were about 3 years into the study, so individuals who were still participating and hadn't had their last visit, were asked to fill out a survey and tell us what types of information was most important to them. I think that you will not be surprised by these findings. So the common side effects of treatment were among the most popular topics, as well as how well the therapy works. What happens after you stop the treatment and the pros and cons of treatment, and also, in particular, how therapies for depression might interact with their existing disease-modifying therapies. And in general, amongst the questions that we asked, there was a big interest in what are the contextual or specific factors that should influence treatment in a person with MS that takes into account their MS. We also found, although there's a big emphasis on the internet these days, that many people wanted to be able to have a face-to-face discussion with a person about their treatment. And we also found, which again may not surprise you, but I think is important to understand, is that the women who responded to our survey almost always wanted to know more information than men on nearly every topic that we asked about. So I'm not going to go into treatments in detail today because I'm not a psychiatrist, but there are a range of available treatments available. So a number of different medications, as well as a number of different psychological therapies, such as counseling and emotion-focused therapy, as well as cognitive behavioral therapy, which works on our thought processes and behaviors for treatment, and that's been studied in person, online, and over the phone. So one of the questions that we wanted to address is what information is available about existing effective therapies for depression in people living with MS. And so this work was conducted by Dr. Kirsten Feist when she was a postdoctoral fellow of mine. So she did a systematic search of the research literature and found 12 clinical trials focusing on this work. So clinical trial, remember, is a kind of study design when people are randomly assigned to a particular treatment, and they and their treating physician usually don't know what treatment they're assigned to, and they're followed over time to compare their treatment responses. So this is the strongest kind of evidence we can get for treatment. So here you will see that we identified 9 psychological therapy trials. Most of them were done as compared to just what the standard usual care that might have been offered to that individual. So if we look at this figure, anything on this side of the graph indicates that the psychological treatment was better than the usual care. So when we combined the effects of all of these studies, the summary measure told us the psychological therapy was effective for people with MS. If we looked at drug therapy trials over here, there were 2 that were compared to usual care. And again, both of these therapies were more effective than just the usual standard care. This particular study, which is also represented over here, compared a psychological and a pharmacological therapy together, and they were no different. We found only one study, although we looked very hard, that looked at treatment of anxiety in people with MS, and that was actually just focused on injection phobia, so particularly around people having difficulty doing injections related to their disease-modifying therapy. So I mentioned to you that an area of importance to people with MS is what's the sort of interaction between depression and anxiety disorders and their disease-modifying therapies. So a student of mine focused on looking at whether there was any information to suggest that what we call a second-generation disease-modifying therapy, so those are our oral therapies, teriflunomide, dimethylfumarate, fingolimod, as well as one of our intravenous therapies, natalizumab, which was available at the time that we did this study, whether they were associated with an increased risk of psychiatric side effects. And as it turns out, after he combined all of the various studies together, we found that there was no risk of problems with depression or anxiety disorders overall with use of these therapies. And in fact, a couple of the studies he looked at suggested that use of disease-modifying therapy, if it was effective, might actually help to improve depressive symptoms. This is not something we could say definitively based on this review because the studies weren't designed to answer that question, but it is something that we think deserves more study. So in conclusion, what I've shared with you today is that the risk of breast and colorectal cancers are the same in people with and without MS, that depression and anxiety disorders affect many people with MS and can affect things like relapse risk, the ability to think and remember, the ability to work well. And so this really highlights the importance of diagnosing and treating depression and anxiety disorders, as well as focusing on MS-specific therapies like disease-modifying therapy. And we know that psychological and drug therapies are effective, so people can have a choice. So I'd just like to thank the supporters of the work that we've been done, and thank you for your attention today. And of course, I would be happy to take any questions.
Wonderful. Thank you so much, Dr. Marrie. Now it is the time for you to participate, and it's time for questions. So again, a reminder, please type your questions into the chat box, the comments section at the bottom of the question box. As we're waiting for those to come in, I will kick us off with a first question. I'd like to ask you a little bit about process. In our world today, the current realities of COVID-19 and how that's impacted the way you work and the pace of research and progress that's going on. Can you give us a little bit of perspective on how that's changed?
That's a good question because it's actually changed quite a lot about what we do. So many of the results of the study that I talked to you about the effects of depression and anxiety on people with MS, we actually wouldn't be allowed to do if it were still running at this time because it's a study that doesn't directly relate to patient care. So important for us to learn, but because it's not related to patient care, it's not considered an activity that's permissible during the pandemic, at least in Manitoba, because of the increased contacts that we're creating for individuals who would be coming in to the hospital for a study visit when they wouldn't otherwise need one. So other studies that we have like that have effectively been halted completely. So studies that require us to be hands-on to do an assessment, we can't do. Studies like the findings that I mentioned about the cancer risk, for example, is a kind of research that's using data that's already been collected. So once everybody was set up with secure portals to work remotely, that work could continue virtually with just every time I have a meeting, it's a virtual meeting or phone meeting rather than an in-person one. So the impacts have really depended heavily on the type of work that was done. It's also halted. We run a clinical trials program here as well because we think it's important to be part of testing new therapies and giving people opportunities to try things that if they haven't already done well with some of our existing choices. And while we were able to continue seeing people who are already in a study, because that's part of the care that they're receiving, and we could say that's important for their well-being, we have not been able to start any new studies like that. So that means there's some studies we won't get the opportunity to participate in at all, which means the people that we care for in our clinic don't have the opportunity to participate. So it's had a dramatic effect in terms of the kinds of things we can do. And because everybody is working at a distance and my team is at a distance, if they have an issue, the troubleshooting, let's just say it's a lot slower trying to figure it out when you can only sort of work at it remotely. So I think everybody's working very, very hard to try and keep things moving forward as much as we can. But there are these constraints that we just can't get around right now.
Sounds like it's a challenge for everybody, but really glad to hear that you're soldiering on. So our next question now is coming from Montreal. Curious about an increased risk of CBD in MS, especially since HTN is higher at diagnosis and HTN is a risk factor for CBD, as is less physical activity, which Dr. Marrie also mentioned. Over to you, Doctor.
Yeah, so it's a good question. So actually, we and others have shown that people with MS do have some increased risks of heart disease and stroke. They do vary a bit with age. And one of the important questions, for instance, if we look at the risk of, say, having a heart attack, is that some of the standard risk factors, like you mentioned, like high blood pressure or high cholesterol, being less active, smoking, are important as they are in other people who develop heart attacks who don't have MS. But our work has also suggested there may be some increased risk that's not accounted for by all the usual risk factors. So that raised some question as to why that might be. It's something that's been reported in other immune diseases like rheumatoid arthritis, for example. And the thought in rheumatoid arthritis has been that it may be related in some way to inflammation playing a role. And as it turns out, that's one of our studies that's been halted. We were actually supposed to do some work to try and look at that question, but we haven't been able to start that study because it was funded just before the pandemic shut everything down, and we still don't have permission to start it up. So I think figuring that out and what one can do to prevent heart attacks is important. So obviously taking care of your other health conditions is critical, and being as active as you can, quitting smoking, those kinds of things. And then we want to see if there's anything else that we should be doing to help reduce those risks.
Very sensible. All right, our next question is about, I understand you've also studied the prevalence of MS in Canada's Indigenous communities. Could you share a few key learnings from that analysis with us?
Sure. So as many of you are likely aware, multiple sclerosis is very common in Canada, and we would be considered one of the countries with the highest prevalence or number of people affected per capita worldwide. So one of the questions that comes up is, does that vary? So people often talk about, does it vary based on where you live? But the other question is, does it vary based on any other characteristics of that person? So their race or ethnicity and so on. So we use, similar to when we were looking at the cancer risk, we use the health claims data to look at the number of people affected with MS who identified themselves as being of First Nations background versus not. And so we found that people who identified as First Nations had a lower likelihood, about a third of what non-First Nations Manitobans would have in terms of the risk of MS. But because people because we're in Canada, that risk is still among the highest in the world. So there's a difference in risk, it's lower, but it's still quite high. So important, and it means we really need to think about that, because historically people might have thought that as a lower risk group may not be as alert to thinking about that possible diagnosis if someone presents with symptoms. But I would say it's still so common, it really needs to be high on the list.
Interesting. All right, our next question is about age. Curious about the age control for comparing comorbid conditions. Like for HTN at diagnosis of MS, is that in older people only?
So good question. So it's not only in older people, but you're right that the likelihood of having high blood pressure diagnosis is higher if you were older at the time of onset. So I didn't show it in my slides today because I needed to keep to the time requirement. But basically, if we were to make a little bar graph, the youngest people would have a percentage of hypertension like this, and then if we get into people who are in their 40s, we're getting a little bit higher, and if we get to people with sort of later onset MS, it gets higher still. So we similarly see that kind of increase with high cholesterol and with diabetes, but there's still enough people, even in our youngest groups, that it means we need to be alert to that.
All right. Now, our next question is about anxiety and depression. Your study very eloquently, and your presentation very eloquently showed the numbers. Is there, did your work cover at all causation? Was that addressed anywhere in the work that you did, that anxiety and depression is there because of the MS, or it's caused by the MS, if that?
This is another key question that everybody wants the answer to. So we actually have tried to start looking at this. Before I get into the details of that, I think I'll say is that probably there are several possible explanations, and it's probably not the same for every single person. So when we looked at the, discovered that we saw the increased risk of depression and anxiety in people with MS, we also looked to see if that was true in people with other immune disorders, and we found a pretty similar pattern in people with inflammatory bowel disease and rheumatoid arthritis. So then we said, okay, well, does this mean this is a feature of all diseases, i.e. caused by, due to some shared factor or not? How could we figure that out? So what we did is we then went to look and see what the risk of depression and anxiety was before the diagnosis of MS. So we actually first looked back 5 years, and we found that there was an increased risk of depression and anxiety even before diagnosis. And it basically sort of rises as you're moving up to the year of diagnosis. So it increases as you get closer to the time of diagnosis. And so we saw that in all 3 of these immune diseases. And then we said, okay, well, can we sneak back a little farther knowing our numbers get smaller because we just had fewer people for whom we had so much time. And there's still a hint even as you start heading out to 10 years out. So that leaves us with the possibility that for some individuals, it's possible that this might be a risk factor. The other possibilities that we could imagine is there might be a shared risk factor. So for instance, could there be a genetic risk factor that puts you at increased risk for depression and anxiety, but also puts you at increased risk for MS, for example? So one of my colleagues here, who's relatively new faculty member, Dr. Karina Kowalik, who actually did some of her training with support from the MS Society, has been doing some work trying to look at that genetics question. So she's been trying to look and see whether genes associated with depression are associated with the risk of MS and vice versa. So far, it doesn't look like that's the case, but there are hints that there might be another genetic factor that's important. So for instance, the genes associated with having an increased tendency to being overweight or obese appear to be associated with both MS and depression. So we are trying to start peeling, that part of the story back. And we've also been trying to look a little bit by going back earlier in life and potentially starting to look at some of these things in children with MS, where there are fewer sort of life events to happen. So it may be easier for us to pick out something that might be important in terms of risk factors. So I think this is actually a very important question. And so we are trying to sort of work through that now.
Excellent, thank you. So our next question has to do with fatigue. Did you have any measure for cognitive fatigue during the immune disease cohort study?
Yeah, so we actually didn't. So, I mean, it's one of the things that we talked about, and one of our collaborators, Dr. John Fisk, has done some work in this area. But one of the things we realized is we were asking an enormous amount of people. So people with MS who participated in this study, some of them were spending 3 hours in a visit with us doing all of these things. And we greatly appreciated the time and effort they took, but, it's exhausting to expect, people to do all of these additional kinds of pieces. So unfortunately, we don't have that piece, and there are many additional things that we would love to have been able to do, but we also needed to, respect that we could make people tired, and if we did a lot of things, that might also influence some of those findings. So it's we need to think about in future studies, particularly whether depression and anxiety might influence cognitive fatigue.
Definitely a huge issue for those of us in the MS community, that's for sure. All right, well, thank you so much, Dr. Marrie. I don't see any other questions standing by from the powers that be. Are there any other questions coming through from the group? Again, a reminder, it's in the chat box. So if you have a question, now's your time. Here we go. Here's our next one. Please tell us about DMT, that's disease-modifying therapies, in association with breast cancer and other cancers.
Yeah, so this has always been a key question, particularly as we start using stronger immunosuppressive therapies. So, if we think about ocrelizumab in particular, for instance, breast cancer, was raised as a particular concern in that clinical trial because there were several cases of breast cancer identified in the treated group and not in the group who was treated with their comparison agents. And actually, that study is part of what prompted me to do the study that I presented to you. So to date, when people have looked, subsequently, when we've been using that drug in clinical practice, there hasn't been to date really any convincing evidence that that medication is increasing the risk. But I think we need bigger numbers and more follow-up over time in order to be really confident about that. There have been some individual specific concerns, less with breast cancer with some of the other therapies, but I think we really need much bigger numbers to get consistency because we really haven't had a consistent signal to date. One of my collaborators, Dr. Helen Tremlett, is actually doing a study right now funded by the Canadian Institutes of Health Research using data from four Canadian provinces to actually look at that where we have much, much bigger numbers, and we'll have the opportunity to answer that question because I think it's something people really want to know when they're making their treatment decisions and they're balancing the potential risks and benefits of therapy.
Excellent. Our next question is about future studies. Will you be looking at the effect of mindfulness meditation on cognitive function and symptoms for MS patients with depression and anxiety as an alternative to medications? Is there any way to study those sorts of opportunities?
Sure. Yeah, so I mean, I have lots of things in principle on the go. Some is trying to understand the risks of things, some is trying to understand impact. And then you're right, once we figure out the why and the what, we actually want to do something about it. So with my colleagues, we have been talking about, again, a little bit impacted in terms of the pandemic about what we can do, but thinking about some options. So some of the things that we've been discussing have been things like, could we improve access to therapy with some of the internet-based cognitive behavioral therapy that it doesn't require a therapist, for example? Would that be an option that could be pursued? And how could we design a study so that if it did show benefit, we could convince governments to make that accessible to people as part of care? So we have been starting to try and apply for grant funding to start doing some of those kinds of assessments. We've also had discussions about whether, so there are therapies like transcranial magnetic stimulation, which is neither a medication nor a psychological kind of therapy that has shown some promise in people without MS in terms of treating depression. And so we're starting to have some conversations with a researcher here who does that kind of work to ask the question whether that would be a good option for people who maybe haven't done well enough with psychological therapy, but for whom adding one more medication onto the list would be a real challenge because, everything comes with, costs and side effects and potentially interactions. So those are definitely sort of top of mind for us. I expect it will take us some time to work through getting the funding and executing for that, but I do agree that having more options for people is important.
Fascinating. All right, our next question has to do with cancer concerns. Are there any increased risks of cancer concerns with the long-term use of steroids as a treatment for relapses?
So I'll preface this by saying, typically in terms of when we're treating relapses, typically we wouldn't normally be using corticosteroids as a long-term therapy. Normally we're using it as a short-term therapy to accelerate recovery because corticosteroids accelerate recovery but don't change long-term outcome. So in that context, I would not expect that sort of the so-called short-term or post-steroid use if you're treating the occasional relapse should influence risk. I'm not aware of any specific data in people with MS looking at chronic corticosteroid use in that way, particularly because it's not sort of typically recommended as a therapy. So I don't think I have data that would back up specifically an answer to that question.
Alrighty, and our next question also has to do with cancers. In your studies, did you look at or find cancers in other spots, specifically mouth cancer? This question's asking about.
Yeah, so in the interest of time, I focused on a couple of specific cancers, and those were our priority cancers because they're common in people with MS and the general population. We did look at the risk of cancers more broadly. So we, considered things like skin cancers and thyroid cancers and blood cancers and so on. For most of the cancers that we found, the risks were pretty similar in people with MS and without MS. We did find a slightly increased risk of brain cancer, but that was mainly driven by what we call a kind of benign tumor in the brain called meningiomas, which we think is mainly because people with MS get more brain MRIs as part of their diagnosis and treatment. So we find them because these are often tumors that people otherwise wouldn't have symptoms from. And we did see an increased risk of bladder cancer, which we think probably reflects the so-called neurogenic bladder that people develop with MS, and increased risks of bladder infections and being more likely to have catheters into the bladder. So it's a risk that's similar to what we see in people with spinal cord injury, for example.
Now our next question, I might muck this up pronunciation-wise, but it's asking about a link to quinolinic acid. Is that within your area, Doctor?
I'm not, I'm not sure precisely what question you're asking, but I don't have any specific information about that particular molecule.
Okay. Well, I want to thank you so much for your dedication to the MS community and for your very insightful presentation today, and for your time in being here live to take questions and give us your results and your expertise. So thank you so much, Dr. Marrie, for your time. It was really worthwhile having you. Thank you.
Well, thank you. I appreciate the opportunity to share our findings with you.
Alrighty, I'm going to move things along now. That is all the time we have for questions today. So we're going to take this opportunity now to thank our sponsors. Our lead sponsor today was Bristol Myers Squibb, and contributing sponsors were Biogen Canada, Novartis Pharmaceuticals Canada, and Roche Canada. They've all provided support to make this conference possible. If you'd like to get involved with the MS Society as a volunteer, please go to the website at mssociety.ca. You can also celebrate MS Awareness Month, which is next month, with us during the second annual virtual carnation pinning. That's on May the 5th. You can join us and take action for MS by showing your support for the MS community by sharing on social media. So I hope you'll join me for the MS Walk. That's coming up on May the 30th, and which this year also happens to be World MS Day. We'll be walking in our own neighborhoods right across Canada again and connecting online to show that no one with MS is alone. You can find out more about registering and donating at mswalks.ca. Now, last but not least, I'd like to thank each and every one of you for taking the time to join us and learn more about MS and MS research today. All of the MS Connect sessions are being recorded and they'll be available for viewing at a later date at msconnect.ca. Now, I look forward to seeing you later today for another research presentation about biomarkers. That'll be with Dr. Alexandre Pratt at 5 p.m. Eastern. And then there'll be a fun and informative session, a social engagement session at 6 p.m. Eastern. And don't miss, we've got another one with Dr. Dahlia Rotstein's presentation about MS in new Canadian immigrants. That's tomorrow. Plus tomorrow there'll be another strength and stretching exercise class. And then we'll also have an Ask the Expert panel discussion, and I'll be rejoining you for that one. So thank you so much for joining us today. We hope to see you at the next session.